Welcome to Silver Solutions Radio, an enlightening and engaging program discussing various topics preparing you and your family for the golden years. Questions, answers, and solutions about taking care of loved ones and helping them to remain independent and enjoy an active and fulfilling life. And now, right at home, in-home care and assistance and WRMN AM 1410 present Silver Solutions Radio.
And so with the popularity of Lion King, it reminds us all about the circle of life. And so, although it's not a topic many of us care to talk about, everybody we know someday will die. And I think that it's everyone's goal to have a peaceful transition. And so to improve our knowledge and make that a possibility, we've invited the experts from Transitions Hospice to talk with us today about hospice and palliative care. And so our guests today are Melissa Popp, who is the Executive Director of Transitions, and Katie Monahan, who is the Business Development Manager of Transitions Hospice and Palliative Care. And so welcome, ladies. Thanks for joining us today. And if you could just please introduce yourself and tell us a little bit about yourself.
Of course. Thank you, Jeanette. My name is Katie Monahan. I'm the Manager of Business Development with Transitions Hospice and was lucky enough to join them back in January. And they are definitely a company that embodies the reasons as to why I believe in hospice, making sure that they are treating everybody with dignity and respect and understanding the individuality of each client that they serve.
Wonderful.
Thank you for having us. This is Melissa Popp. I'm the Executive Director. And I've been with Transitions for about 6 years, and I'm an RN as well. So thanks
welcome.
Again.
Sure.
Welcome. Well, ladies and everybody, we have coffee and get to know each other before the show, though a lot of us know each other already. But it's a time for us to check and get caught up. And one of the important topics, and we had said we were going to be talking about hospice today. One of the important things that we talked about this morning was palliative care. So can one of you explain to our audience what palliative care is?
Of course. This is Katie again. You know, palliative care and hospice, I think, often get really confused. People kind of mistake one for the other. But palliative care is the idea that we're going to look at a certain type of care. We're going to make sure that we're taking care of comfort measures, that we're managing pain, we're managing discomfort, we're managing chronic conditions. But palliative care will go ahead and allow for individuals to continue to receive what we think of as aggressive treatment. So things like chemotherapy for individuals with cancer or radiation, individuals who with kidney failures still need dialysis. Different exploratory surgeries, reasons that people would be going back and forth to a hospital. So individuals can still continue to receive that type of care while they also receive the comfort measures of palliative care. I think the other benefit to palliative care is that our nurse practitioners who are at the forefront of palliative care sort of act like a quarterback for the team for that patient. Oftentimes individuals who are using palliative care have more than one doctor. Mm-hmm. They might have a cardiologist, an oncologist, a nephrologist, a pulmonologist, an endocrinologist, you name the gists, they might have it. And we need to make sure that all of those physicians are communicating with each other. So what we do is we make sure that we look through all of the notes and we make sure that medications that are being prescribed don't contraindicate one another. And we make sure that their individuals are receiving the best level of care that they can and put the patient really at the front of the process rather than necessarily the disease at the front of the process. So it's a more personalized approach to care.
So can I ask you, when does that come into play? Like, who do you ask for it, or does the doctor subscribe it or prescribe it? How do you get palliative care?
Melissa, do you want to discuss that?
Yeah, so palliative care can be provided to anybody, typically with any sort of an illness that they've been dealing with for a long time. It doesn't need to be a terminal illness, but it could be something that is acute or long-standing illness.
Okay.
And you would get an order from your doctor, and you would give us a call, and we would, send somebody out within 72 hours.
Okay, got it.
And so now focusing on hospice, and if you would, feel free to address kind of any misconceptions, about hospice while you're describing
You mean
it.
there are misconceptions for hospice?
One or two, yes, perhaps.
I think hospice gets a bad rap. There's a lot of stigma that goes around with hospice. I think a lot of people just hear hospice and they think automatically, oh my gosh, I'm going to die right now. And the reality is that hospice does not prolong life, but hospice also doesn't hasten death. Hospice is a number of services that can be provided for individuals who simply meet the criteria of having a diagnosis that without intensive treatment, the likelihood is that their prognosis is that they're probably going to be gone in about 6 months or less. Now, as I also talk to most of my patients, I have yet to ever meet a doctor with a crystal ball. Mm-hmm. So just because you have the prognosis doesn't necessarily mean that's the truth. My own grandmother was on hospice for almost 3 years. We hear that story more and more often about individuals who understand that hospice is a benefit that people can use that actually can provide a lot of really great care at end of life and give them a much better quality of life as they're able to go ahead and move forward. But that primary diagnosis that they need is that an individual has a condition that without treatment, their prognosis is expected to be 6 months or less.
I have just one follow-up now that I've got some experts here. Have you seen, it just popped, have you seen any difference between, like when you're talking to baby boomers versus the greatest generation, about how they view hospice or their or the family unit? Have you seen any shift in being more accepting or not?
I find that individuals in the greatest generation tend to be a little bit more resistant. Let's be honest, they are the greatest generation. They're going to live forever. And they're not as interested in some of the hospice services right off the bat. Once they understand what they get under hospice services, with all the services of the nurses and the CNAs and the social workers and the bereavement coordination and the chaplains and the volunteers and the music therapy and you name it, they're a little bit more keen on it, especially when they find out that it's no cost to them.
Yes, that's because they're frugal. That's a frugal generation.
Very
Yes.
frugal.
When they're understanding the depression mindset and
yes.
going up through that, they're keeping their pennies close to them. But we find that the baby boomers are a little bit more open to it because they've been through it with their parents before.
Yes.
They've experienced it and they see the benefit of hospice. And it's very rare that I hear from people who say they've had a bad experience with hospice. It does happen every once in a while, but for most people, they have a pretty positive experience. And they're able to see the benefit and understand that by bringing in hospice, it allows them to take a break from being caregiver and now be wife or daughter or son or husband for their loved one.
Such a good point. We hear a lot of, I wish I had called them sooner. We hear that an awful lot.
In fact, could you kind of cover that? I wish I had called hospice sooner, because that's a challenge we all see in the healthcare industry. It's usually within the last couple weeks of life that hospice comes in. But if they have proper care earlier, they can mean a better quality of life. Can you cover that a little bit?
Absolutely. We use it in the terminology when we talk about individuals who are afflicted with chronic illnesses or with cancer. They're fighting. And so unfortunately, a lot of people think when you call hospice, that means you're giving up. And the reality is that you're not giving up. You're making a decision. And that decision is that you've decided that your quality of life is worth more to you necessarily than your quantity. And making sure that you get to live the rest of your life the way you want to. We have individuals on hospice who are finally able to go to that Cubs game, or they're able to, be comfortable enough to be able to have all the grandkids over and be able to share stories with them, because they're not in chronic pain anymore. It gives us the opportunity to sort of, again, be in control of our own lives and let nature take its course the way whatever you believe in is intending it to do so, and lets people just go ahead and be comfortable all the way to the end. I think people's biggest fear, at least what I've learned so far with my experience, is that people are afraid of pain. And people are afraid that they're going to be suffering at the end. And the goal for hospice is to reduce and even eliminate pain wherever we can and make sure that there is no suffering, which is why we have all the services that we have. We have the medical services with the nurse and our CNAs to make sure that people have their physical pain taken care of. We have social workers on hand and bereavement coordinators to make sure that emotional pain is addressed. And we have chaplains to make sure that spiritual pain is addressed. So in a way, hospice really is that sort of first holistic medical practice to make sure that people can get what they need. And isn't it a shame that we're only doing that at the end of life?
Mm-hmm.
Right. Yeah.
And one of the primary parts of hospice is addressing the spiritual. And you had mentioned your grandmother, was on hospice for 3 years. And I know all of us have had clients in and out of hospice that once they made a decision to go to hospice and address that spiritual component of life, they have had a longer and a quality of life than they would have had by.
Absolutely. My grandmother was on hospice, as was Melissa's. So we have firsthand experience as family members witnessing just the joy that can be brought through hospice. And I know one of my grandmother's favorite things that ever happened. Now she had dementia, but whenever the music therapist came in and would sing with her, she would light up, and you would completely forget that this woman was dying and that she had dementia because she was having so much fun. I mean, Melissa, what was your experience with hospice with your grandma?
Mine was the same with my grandma. She was a kindergarten teacher, so she loved singing. And two of her nurses, Jen and Vicky, who still work with us, would come and sing bedside with her. And she was nonverbal, but she would find the words to those songs.
Oh, yeah, the music has an emotional
Absolutely
component there that
really
reaches
does.
in.
Mhm.
Yep. Mm-hmm.
And so who can receive care? Are there any restrictions or?
So anybody can receive care that has a terminal illness with the expected prognosis of 6 months or less.
Okay.
And it is covered 100% by the Medicare A hospice benefit, also commercial insurance and Medicaid.
Okay, so commercial insurance does cover it too.
And then we're also part of the We Honor Veterans program through the VA. So we're also able to provide VA benefits for individuals who receive their services through the VA. And that is covered at 100% as well.
Wonderful.
Katie, you did a great job of covering this before, but if we can, let's cover the services provided by hospice.
Okay, so when we start hospice, the patient will go ahead and meet with one of our regional hospice coordinators to sign consents, because hospice is voluntary. So I want to make sure everybody who's listening knows that, and you get to choose your hospice. And if you are not happy with your hospice, you get to switch your hospice. And that's when you get to call transitions. But we'll come out and we'll meet with you and we'll discuss the different services that are available to you under hospice. We'll do a consent signing, which consents for the patient to be treated by our nurses and be assessed. It's also a financial form to make sure that they understand that we're going to be billing their insurance. And then at that point, a nurse will go ahead, same day, to go ahead and do the assessment whenever possible. And we're a little different. We will admit 24 hours. So if we need to admit at 2 o'clock in the afternoon, at 2 o'clock in the morning, we can go ahead and accommodate for that. We then have a whole bunch of different levels of care that can be provided. Our routine level of care provides the services of a nurse, of a CNA, of a social worker, and of a chaplain. And those, of course, are based on what the individual needs. We don't believe that a cookie cutter approach to hospice makes any sense. So we're going to go ahead and do that individualized approach to care. And on average, we'll see our patients a couple times a week with a nurse, a couple times a week with the CNA, social worker, once, twice a week as needed. But as the level of care progresses and as people need more care, we can go to daily visits, we can go to twice a day visits, and we even have a program that we call our vigil care, which allows for us to be with a patient 24 hours so that we're there to make sure that no one dies alone. And we're pretty proud of the fact that we're able to do that. We have almost a 94% rate of making sure that we are bedside with our patients at end of life. Because again, we really don't believe that anybody should be alone at end of life.
94% is awesome.
Well, considering the fact the national average is under 20%, we're pretty proud of that.
That right there is big. It's huge. Yeah.
And so we talked about how the services are paid for and who provides the services. So let's just skip over to where the care is provided.
Care is provided wherever the patient may call home. So it could be a private residence, assisted living facility, skilled nursing facility. So wherever they call home, we will be there.
And so a skilled nursing facility, there's already skill there. So how does hospice come into play?
Hospice is just an additional added benefit to the services that they're already getting. So and we would come in on top of the care that they're already receiving. So it's extra care.
Okay.
Could you speak to just look, I know you touched on it, but kind of treatment and hospice and treatment and palliative care, kind of how does that work on the hospice side?
So I'll start with hospice. With hospice, you're just really looking for comfort measures. Really aggressive treatments are stopped, and you just focus on, comfort and quality of life. With palliative care, you can continue to pursue aggressive medications, aggressive treatments. So again, with hospice, you're going for comfort. Palliative is a comfort and still with aggressive measures.
So you could be having dialysis and be on palliative care.
Correct.
And you can still be having chemo and be on palliative care.
Correct.
I think the other misconception that people hear about hospice is they think that as soon as hospice comes in, we just stop all medications. And that's not the case. We'll continue medications that are continually used for comfort measures. So, and that's assessed on an individual basis. So, if there's a medication that's really helping to manage maybe blood clots, obviously, we want to make sure that we can continue to manage that so that we don't end up throwing a clot into the lungs and causing a pulmonary embolism. So we'll continue that. But it's not a idea that we're simply coming in and wiping the slate clean and just giving people morphine until they pass. Our goal is comfort measures, and we are going to do everything that we can to make sure that an individual is comfortable. And we've been able to do that in the home setting since 2007.
Wow.
Cool. And you can adjust, like if they're having trouble swallowing, you can adjust the method that they're receiving. Maybe it's liquids or medication.
Yes, absolutely. Yeah. So we can change the diet. So if they're on a regular diet and having difficulty swallowing, we can change it to, softer foods. Or if they're having difficulty swallowing their medications, we can crush the pills depending on the type of medication it is. Or again, with the fluids, we can thicken them, which makes it easier to swallow as well.
And it's amazing what pharmacies can do these days. You can find a lot of medications now in liquid suspension. And sometimes an eyedropper can be the best use of being able to go ahead and administer medication, especially if we're trying to do something under the tongue.
Sure. And so how long is the care provided? Obviously, we know until the end, but is there a period of time? And if the person doesn't pass away within that period of time, does hospice stop? How does that work?
So our team reviews the eligibility. of each individual. For the first 2 certification periods, they're each 90 days. Thereafter, the care and eligibility is reviewed every 60 days. So, as long as the individual is showing decline and still has the, terminal illness, they would continue to qualify. We do have individuals that we call graduate from hospice care because with the additional, services that they're getting and additional care, we see improvements. So
Fantastic.
we actually saw my own grandmother gain 12 pounds when she was on hospice the first time around. And she had 2 certifications of hospice that time around, and then she graduated. And then she was off hospice for about 3 months, and then we started to see a decline again, and we got her onto hospice again. And that's the beauty of hospice. You can graduate off of hospice and then go back on hospice when there is another decline. And you can do that as many times, really, as the body needs. So every once in a while, people can use hospice and actually improve, which is, again, when we have those graduates. But our goal is to make sure that we stay on top of things. And the fact that we have the palliative care side allows us to transfer our patients from hospice to palliative care when appropriate so that we can really monitor those patients. And if we see that decline come again, that allows us to go ahead and get hospice involved much earlier so that individuals can experience all the benefits of hospice care.
Wonderful. And so we're running out of time already. So I want to talk about DME. Now, that's something really specific to transitions. And durable medical equipment is what DME stands for. But can you tell us about that and how transition and why transitions provides that?
So the durable medical equipment is another benefit of the hospice benefit. So we would provide any equipment that they need in order to make them live better or related to their illness. For example, wheelchairs, walkers, hospital beds, et cetera, that anything, that would they need on that side of things, we would also provide.
And it makes it a lot easier because your nurse is requesting it versus trying to coordinate it with another company. So it seems like it would be really a smooth transition.
Correct. With home health, it's a little trickier to get these pieces of equipment in place. With hospice, our nurse identifies that the individual needs a hospital bed, and we could get it out there within hours.
Yeah, that's amazing. And then we wanted to talk about grief support too.
Absolutely. Transitions Hospice has a very active bereavement group and team that makes sure that we are there and available not only for our patients but also for the family members. A lot of people don't realize that bereavement support is available to the family for up to 13 months after the passing of their loved one. So we like to stay sort of on top of that, which is why we have our transitions support group. And it actually takes place on the second Tuesday of every month. It's at 6:30 in the evening to accommodate for those individuals who work. And it's at our transitions location in Naperville, which is at 1551 Bond Street, number 143. Again, that's in Naperville. And it's a support group for adults who have experienced the death of a loved one to really help them explore and discuss their feelings in a supportive and comfortable and confidential environment while meeting with others who have experienced loss. And it's led by our bereavement coordinator, Leslie Kula Leitner, who is a master's level trained social worker and a licensed clinical social worker. And she put this group together as a way to support the community as well as extra support for our patient families.
Katie, is this open to everybody?
Yeah. Is it open to everyone or does it have to be transition clients?
Oh, no, it's open to anybody.
Okay.
Anybody who has experienced loss or is going through the grieving process, we want to make sure that they understand that it's open to them as well.
Wonderful. Well, unfortunately, time flies when you're having fun. It goes by in the wink of an eye. That's what we always say.
Course.
We know that.
Jeanette, Jim, and Kathy, we thank you so much for letting us be a part of your talk show today.
Well, thanks, Katie. I want you to share the information about Transitions Hospice one more time.
Absolutely. So Transitions Hospice and Palliative Care can be reached at area code 847-515-1505, or you can look us up on the web at www.transitionshospice.com.
Thank you so much for being our guest today.
Yes, thank you guys for being here, and thank you for what you do.